everyone, we are from Group 1 for Medical Microbiology, and today we're going to do case study presentation. Here are our group members.
Hello everyone. Today I'll be presenting a case study of a 27-year-old male who visited a clinic in Barcelona, Spain on July 28, 2022, presenting with a fever and a rash. The rash began as small vesicles on his face and mouth and progressively spread to the rest of his body. Initial suspicions included varicella zoster virus and HIV. However, diagnostic tests for both were negative. 5 days later, with no improvement, the patient was admitted to the hospital exhibiting a fever of 39 degrees Celsius, cough, and generalized rash characterized by round, pustular, raised, and deep-seated lesions that evolved to umbilicated forms and crusted after 7 days. To better understand the patient's condition, several important questions are considered. What is the patient's recent travel history, and could it indicate exposure to region-specific infections like monkeypox or dengue? Has he ever been in contact with individuals or animals showing similar symptoms suggesting zoonotic or human-to-human transmission? What is his sexual history given the initial HIV suspicion to evaluate potential STI or bloodborne pathogen exposure? Is he immunocompromised or on medications that could alter his immune response? How did his symptoms develop and progress, and are there additional systemic symptoms like joint pain or gastrointestinal issues? Does he have a history of skin conditions or allergies that might mimic infectious rashes? Finally, have there been any recent environmental changes or chemical exposures that could point to non-infectious triggers? These questions are crucial for refining the diagnosis and guiding treatment.
Now, I will be talking about the most probable diagnosis. The clinical presentation of this patient, particularly with fever, vesicular rash that progressed to pustular and umbilicated lesions, and the distribution of the rash on the face, mouth, arms, palms, trunk, and legs, is highly suggestive of monkeypox. The described rash started as vesicular, then became pustular, and eventually crusted over, following a characteristic progression. The presence of umbilicated lesions is a notable feature often seen in monkeypox. The rash is also consistent with the typical distribution of monkeypox. The involvement of the palms and soles in particular is a hallmark of this infection. Though initially suspected to be varicella zoster virus infection, the negative diagnostic test for varicella, also commonly known as chickenpox, along with HIV, further support the idea of monkeypox, as it can mimic the clinical appearance of chickenpox, but it has a different viral etiology. Systemic symptoms such as fever, cough, and generalized rash in combination with this characteristic skin lesions strongly point to monkeypox. To conclude, monkeypox is the most likely diagnosis based on the given clinical presentation. However, other differential diagnoses could include conditions like smallpox or other poxvirus infections, although these are less likely given the modern context.
The monkeypox virus, an orthopox virus related to smallpox, is a causative agent. It spreads zoonotically through human contact, including close physical contact, respiratory droplets, or bodily fluids. The virus replicates at the entry site, skin, or respiratory tract, then spreads to lymph nodes and causes viremia. Symptoms include fever, fatigue, and a rash that progresses from vesicles to pustules and crusts. It primarily targets epithelial cells, forming characteristic umbilicated lesions.
In innate immune response, the virus activates an immune response through pathways like Toll-like receptors or TLRs, which detect viral particles. Infected cells release cytokines, causing fever and systemic symptoms, and in adaptive immune response, antibody production and cytotoxic T cells help control the infection. Monkeypox can evade immune defenses by producing viral proteins that inhibit interferons and other immune mechanisms. To diagnose monkeypox and rule out other conditions, several methods are used. 1. PCR testing, the gold standard, detecting monkeypox DNA from lesions or throat swabs. 2. Viral culture, confirms orthopox virus but is slower and less commonly used. 3. Electron microscopy, identifies poxvirus particles but doesn't distinguish monkeypox. 4. Serological testing, detects IgM and IgG antibodies, though less effective in early stages. 5. Histopathology. Skin biopsies reveal changes specific to monkeypox. 6. Orthopoxvirus testing. Confirms orthopoxvirus involvement. Genetic testing differentiates species. 7. Exclusion test. Rules out mimickers like varicella zoster or measles. 8. Epidemiology. Travel history, exposure, and rash patterns supports the diagnosis. Combining PCR with clinical and epidemiological data ensures accurate confirmation.
Now, what are some other signs and symptoms of the disease that may be exhibited and experienced by patients who have similar condition? In addition to the fever and rash, patients with monkeypox may exhibit the following signs and symptoms. Lymphadenopathy, which is a swelling of the lymph nodes, particularly in the cervical, axillary, or inguinal regions. Myalgia and fatigue, whereby muscle aches and general malaise are common. Headaches are often accompanied by the fever, back pain, which occurs early in the disease course, and of course, respiratory symptoms such as coughs.
As of now, there is no specific treatment for infections caused by the monkeypox virus. The majority of monkeypox patients with healthy immune system and no skin condition recover with supportive care and pain management without the need of medical intervention. However, seeing the condition of this patient, the persistent fever, respiratory system, widespread rash, and admission to the hospital indicate that in this case the monkeypox may have been considered moderate to severe. For people with severe illness, antivirals can help lessen the symptoms, although there is little evidence to support their efficiency in treating monkeypox. For patients with severe monkeypox, the UK HSA and US CDC have licensed Cidofovir, Brinsupridovir, and Tecovirimat. Tecovirimat works by specifically targeting the VP37 protein. It prevents the virus from leaving the infected cells by blocking the last stages of virus maturation. Tecovirimat was successful in lowering smallpox, monkeypox, and cowpox mortality rates based on animal trials. The data that is now present indicates that a 5-day course is adequate to produce clinical response, whereas a 2-week course allows for humoral immunity to develop and results in long-lasting viral clearance. The treatment of this patient would include the use of ibuprofen to manage fever and alleviate pain associated with the rash, cleansing of the lesions gently with saline or antiseptic solution to prevent secondary bacterial infection, applying calamine lotion or antihistamine to reduce itching, prescribing Tecovirimat, which is a first-line antiviral approved for monkeypox. The dosage is 600 mg orally twice a day with a high-fat meal for 14 days for the patient. For the cough, a cough suppressant should be prescribed or warm saline gargles for systematic relief. With these approaches, the patient should improve within 2 to 4 weeks. Preventing monkeypox involves measures to reduce exposure and improve hygiene practices. For hospitalized cases of monkeypox, the CDC advises isolation in a negative pressure room. For contact and airborne transmission precautions, the Spanish Ministry of Health advises personnel treating a mpox case to wear PEP, such as gown, gloves, eye protection, and FFP2 masks. Patients who are infected and have active skin lesions should be kept apart at home and should take every precaution to avoid contact with their pets and surroundings until the scabs have fallen off and a new layer of skin has grown. It has been demonstrated that the recipients of smallpox vaccine have residual IgG and neutralizing antibodies. Small vaccine recipients demonstrate immunological response against orthopox virus. The only orthopox virus vaccine with the FDA license was ACAM 2000. It lessens the symptoms, however, it doesn't prevent mpox. The US Advisory Committee on Immunization Practices approved the Jynneos vaccine in November 2021 as an alternative to the ACAM 2000.
To conclude, this case study examines a 27-year-old male in Barcelona diagnosed with monkeypox, presenting with fever, pustular rashes, and umbilicated lesions. The diagnostic process involved ruling out varicella zoster and HIV, with monkeypox confirmed through PCR testing. Treatment recommendations include supportive care and the use of antivirals such as Tecovirimat for more severe cases. Preventative strategies emphasize vaccination, maintaining hygiene, isolation, and avoiding close contact with infected individuals or animals. This case highlights the critical role of prompt diagnosis, effective management, and robust public health measures in addressing outbreaks of re-emerging infectious diseases. Here are our references. Thank you for your attention.